What we're going to do today is we're going to walk through AP and PA chest x-ray, and we're going to look at the textbook positioning both out of Merrill's and Bontrager's, and then we're going to look at correction for mispositioning, and those images are going to come out of the Martinson Radiographic Image Analysis book. So this PowerPoint presentation, I took slides from each one of the publisher PowerPoint presentations, put them together into this one. Most of the time I'll take a PowerPoint presentation from the publisher and it is heavily edited. So I'll only use about 10% of what they provide. And in this case, that's not the case. I probably added 10% and did some color coding to help draw your eye to specific things. So these were well enough done and comprehensive enough that I didn't have to do just a tremendous amount of editing. That said, it takes a long time, longer than what you would think, to take PowerPoint presentations from 3 different sources and shuffle them together and put them into a presentation that flows, hopefully, and also is sequenced similarly. So it still takes several hours, but it's certainly not, does not take as long as writing one from scratch, which is essentially what I've done before. So these are pretty close to what if your instructor uses the publisher PowerPoints, is going to be pretty familiar to you. But I wanted to include both the Merrill's and the Bontrager's because they're the two most common positioning textbooks that people will use, and I wanted it to be familiar to a reviewer. So you're going to see elements of both of those things in here. So let's just jump right into it and talk about indications for why we might shoot a chest x-ray. So the most common 2 chest x-rays that we're going to shoot are an AP or a PA. If the patient can come to the department, we're probably going to do a PA and lateral, but in a lot of cases, the patient can't come to the department. So, or if they can come to the department, they can't stand up to perform a PA projection. Projection is what I'm referring to with PA. PA projection indicates that the x-ray beam goes to the patient's back and exits the patient's front. An AP projection would go on the patient's front and exit the back. So this would be anterior-posterior versus posterior-anterior projection. So the most common, if the patient can stand up, would be a PA projection. But if we have to take the machine to the patient's room, it's probably going to be an AP projection. Even some of the exams that we're going to take in the department are going to be AP projection. So the indications for chest x-ray are going to be a sign, a symptom, a medical condition leads to the recommendation of a treatment, test, or procedure. So what an indication is a reason that we do a particular exam, and there are a lot of different reasons, and within each one of those reasons there may be a sub-reason. So short of breath could be caused by a number of different things. Maybe the patient has pneumonia. They may have a situation where their lung is collapsed, and that would be what we refer to as atelectasis, leading to, in a lot of cases, what we refer to as pneumothorax. And a pneumothorax is air inside the thoracic cavity but outside of the lung. So certainly that could cause you to be short of breath if your lung is not inflated properly. Aspiration would be that something went down the wrong pipe. Instead of going down your esophagus into your stomach, it went into your lungs, and that could lead to, if it's a solid thing, a foreign body. And if it's a foreign body, it could completely occlude or block one of your airways, usually the right main stem, one of the right bronchi, and therefore reduce your capacity for breathing. Maybe we're looking for a feeding tube placement or a central line placement, and I'll take each one of those individually. A feeding tube generally goes through the patient's nose, and you want to see it go beneath the diaphragm into the stomach. But the place that it might go, the most common mispositioning of a feeding tube may be that it goes into the right mainstem bronchus. Sometimes it'll hit some sort of, not really obstruction, but some sort of anatomy on the way down, and just kind of roll up in the airway, in the upper airway. So we might do a chest X-ray. They might order a KUB, which is an abdomen X-ray. It stands for kidneys, ureters, and bladder, to see where the feeding tube is. And in that case, we're not really going to shoot a chest X-ray. We're not really going to shoot an abdomen. We're going to shoot somewhere in between. But they may enter it as a chest X-ray, and as a chest X-ray, what they might ask for is feeding tube placement. Central line placement is something completely different. And what that is kind of like a really, really good IV. So what they're going to do is they're going to put this IV sometimes into the patient's jugular vein, and sometimes in the subclavian vein. And what they want to see is it going down into the superior vena cava, possibly into the right atrium. So you want to see it going down. Sometimes it makes a turn, especially if it's in the subclavian, and it might go up instead of down. So it may go into the internal external jugular instead of into the vena cava. So it may be placement of a chest tube. The patient may have a history of pneumonia, maybe a persistent cough, maybe a central line placement. I just talked about that. Maybe the patient's wheezing. Maybe they have COPD. If the patient's wheezing and they have COPD, what do they have going on? Do they have consistent bronchitis? Do they have asthma? Do they have emphysema? What's going on with the patient? But also history of exposure to pathogens, like potentially any kind of caustic chemical that may cause what they would refer to as consolidation, all the way up to maybe the patient had asbestos exposure and they've got asbestosis, or potentially what they're looking for is follow-up in comparison to previous views to see if the patient's getting any better. So a lot of different reasons for potentially for shooting a chest X-ray. It's not a comprehensive list. That's just some examples. So our procedural guidelines, some of this I discussed in the previous video. Patient preparation, what I really recommend you do is just dress the patient in a gown, have them take off everything from their waist up and put on a gown, just to make sure that you don't have any issues with artifacts, and we'll talk about that here in a second. So most of the time we want the patient in general position of the patient to be upright so that we can get a PA chest X-ray. Even if we can't get a PA chest X-ray, we want the patient upright so that we can see air fluid levels. If the patient can't stand up, then we can do some other things to demonstrate those air fluid levels, but preferably we want the patient upright. Source to image receptor distances, if at all possible, on a chest X-ray, we're going to use 72 inches. Sometimes you can't get 72 inches, you're going to have to settle for 40, but if at all possible, you need to try to get 72 inches. And the reason for that is because magnification of the heart becomes an issue. Your heart is more anterior than posterior, but you can't put your heart all the way up against the image receptor. So you're going to have an increase in object to image receptor distance, and to mitigate that and make it not show the heart not look magnified, we're going to back up our source to image receptor distance to 72 inches. So your image receptor always fit the part. So if you have a pediatric patient and you have access to a smaller image receptor, you would use that smaller image receptor. Always your collimation should be to the part and never larger than the image receptor that you're using. Our identification markers, you always want to use one. That's your side marker. And you always want to make sure that you use the proper one. And you want to follow hospital protocol and position of those markers. Sometimes your radiologists are going to be very specific and particular on how they want the images marked. So follow protocol. Radiation protection, the main thing on radiation protection is going to be proper technical factors, but also beam restriction. And then your hospital protocol is what you're going to defer to for things like shielding. Your patient instructions are very important. Tell your patient what you're going to do, what you need them to do, and if there's breathing instructions, include those as well. We'll talk about those in a bit. So removal of artifacts specifically for chest x-rays, you want to get rid of long earrings that could cover the apex or the top of the lungs. Necklaces, same thing. But clothing artifacts like snaps, buttons, puffy paint, thick elastic or anything like that needs to come off of the patient. Long hair fasteners that may cover the lung field need to come out, but also you need to be aware that synthetic hair shows up. So if the patient's wearing a wig or if they have a weave or anything like that, it's going to show up in the image. Make sure that any lines that can be removed get removed, not removed from the patient, but from what would be the shadow of the patient's anatomy. So if the patient has an O2 line, then that could go over the top of the bucky in this case. Feeding tube can also go over the top of the bucky. It's going to be pretty tender because it's going in the patient's nose. Telemetry lead, I spoke about this in the previous video, but your tendency is to want to look at your telemetry leads, and that's heart monitor with leads, the wires that plug into the patient's chest, is to take those and put them on top of the image receptor, or top of the bucky, along with all the other stuff. But it really is not the best place for them. So what you want to do is take those leads out of the harness and the telemetry device, the heart monitor, out of the harness and just lower it down in front of the patient so it pulls those leads tight straight down towards the patient's feet. It really gets them out of the way the best. So external pacemakers are a thing, and they would follow your telemetry. If the patient has an internal pacemaker, you can't really do anything about that. But external pacemakers you can. And then I've never worked in a hospital where the technologist was responsible for taking the patient's personal belongings and putting them into a designated place or a safe place. I don't recommend that. So what I recommend you do is if the patient takes their earrings off or the rings off, if you're doing hands and necklaces and things like that, take those and put them maybe in a specimen cup and give them to the patient. So one thing about this image that just kind of works on me a little bit is that the top of the image receptor should correspond to that line, and our collimative field is above that by about 3/4 to an inch. So again, there's never any reason that the lines on your bucky indicate where the edges of the image receptor should be, and there's no reason to have light beyond that. Your light field, if your machine is calibrated properly, should correspond to the radiation field that you eventually create. So I just needed to point that out. So general patient position, ambulatory patients, you want them upright if at all possible, and they could be upright standing, or they could be seated upright. Again, I talked about that in the previous video. Some of your wheelchairs, the backs and the sides will come off of those wheelchairs, and it makes it ideal to be able to shoot AP chest x-ray, PA chest x-ray, whatever you need to at the wall bucky. But your non-ambulatory patients are going to be a little bit more of a challenge. If you need to visualize air fluid levels, we might have to do some special things we'll talk about here in a bit. And that would be to put the patient in a decubitus position. And I touched on this again in the previous video. A decubitus in diagnostic radiology, decubitus means two things. One is that the patient's laying down, typically on one of their sides, and we utilize a horizontal central ray. So the reasons for an erect chest x-ray are some of those things. So we've got a few things. One is that if the patient's laying on the table, you can't get 72 inches. 72 inches is important for a chest x-ray to minimize the magnification of that heart. So that doesn't appear here, but it is an important thing. So 72 inches allows 72 inches. It also allows the diaphragm to move to its lowest possible level. So if you're laying on your back and you breathe in deep, you're not going to be able to breathe as deeply as if you are standing up. So it allows for deeper inspiration. Inspiration and inhalation mean the same thing. So it allows for deeper inhalation. Since we're looking for the lungs, and we're looking for the heart, then it's important to maximally inflate the lungs. It also can give us a demonstration of air fluid levels, and it also prevents the engorgement of the pulmonary vessels. So I want to relate a little bit of a story. Most of the time you don't see this, but sometimes it's pretty dramatic. So if a patient's laying flat on their back, and their superior vena cava can engorge with blood, and it can widen, and it can make it look like the patient has some sort of pathology inside their mediastinum, in between the two lungs. So I had a trauma patient one time, and it was a minimum trauma patient. The patient came to us on a backboard. He was fine. We had to take a lot of x-rays. I don't even remember him going to CT for neck x-ray or for neck CT or anything like that. I think he was clinically cleared, and with diagnostic x-rays he was cleared, and he was sent home that day. Usually the first image that you shoot in a trauma situation is chest x-ray, and that is because if there's something going on in the lungs, it doesn't matter if they've got a broken neck, they're going to suffocate before they can get to the OR and have their neck fixed, right? So the first image that we shoot in a trauma situation is chest x-ray. And this guy, his mediastinum looked really wide, but clinically he wasn't complaining of back pain or chest pain or anything like that. So the ER doc, who was a fantastic clinician, he didn't get in too big of a twist about it. But once we got the patient off of the backboard, we took x-rays of his neck and his back and anything else that hurt. He said, let's get this guy up and take a normal chest x-ray with him upright. So we did, and that wide mediastinum that would have indicated that potentially he had a ruptured vessel in his mediastinum proved to not be an issue. Those pulmonary vessels drained, his vena cava drained, and we could tell that his mediastinum was just fine. So for all those reasons, we want to do the patient upright if at all possible. So our radiation protection for our chest x-ray, we talked a little bit about this in the previous video, is one, to limit repeat exposure. So you need to approach every x-ray that you shoot as if you're trying to make it perfect. You're not going to make everyone perfect. You're not even going to make everyone acceptable, right? So you're going to repeat some exams, but that doesn't mean that you shouldn't make every exam or try to make every exam perfect. Try to make every exam perfect, and then whenever you get a good one, understand that not everyone can be perfect. Collimation. Make sure that you use beam restriction, collimate in as closely as possible without increasing the likelihood that you're going to exclude anatomy of interest or clip it and not have it on the image receptor. Gonadal shielding, again, there's a big debate as to whether or not we should be using gonadal shielding, and until there's a consensus, just follow your hospital protocol. The patient instructions are going to be, you want to be very deliberate and succinct in your patient instructions. Don't overload the patient all at one time, but feed them the information that they need whenever they need to have it. Like, you wheel the patient up to the wall bucky and you ask them, can you stand up? Lock the wheelchair, and then ask them, can you stand up? They stand up and you say, I need you to put your chest up against this board. Don't overcomplicate it and say, I need you to put your anterior thoracic cavity against this wall bucky. I don't know what you're talking about. Can you put your chest against this board? So take it step by step. Our respiratory instructions can be very specific for chest x-ray, and they're not going to be the same for anything else we shoot. So respiration is going to be intended to maximize how much lung we can see. And that is that we're usually going to make our exposure after the second deep inspiration. So you're going to tell your patient to take in a big deep breath, blow their breath all the way out, take in a second big deep breath, and hold their breath after that second one. The reason for that is the same reason that if you're going to swim for a distance underwater, you're going to take in a couple of big deep breaths and blow them out before you take in one big one and go underwater. And that is because off of that first inspiration, your lungs are not going to inflate as well as what they will after, 2 or 3 of them. This is sufficient for what we're going to need to do. You don't even need to do 2 for subsequent views. So our most common routine for chest x-ray is a PA and a left lateral. You don't need to do 2 deep inspirations for lateral. So just the PA, unless you shoot the lateral first. That's something totally different. So full inspiration, expose after the second full inspiration. So there are times, though, excuse me, where we may take 2 images, one on inspiration, one on expiration. And really, we've got 2 things that really mean the same thing. So atelectasis means the collapse of a lung. The question is, what caused the collapse of the lung? So if we've got a puncture of the lung because maybe the patient had a broken rib or maybe a broken collarbone that punctured the lung, then we've got atelectasis, but we're also going to have what we refer to as pneumothorax. So a pneumothorax is air inside the thoracic cavity, but outside of the lung. And if it's a small pneumothorax, then what we may find is that the edge of the lung may follow the rib very closely. So we increase our chances of being able to visualize the edge of the lung if we do inspiration and expiration chest x-rays. So that's one example. Diaphragm movement and presence of foreign body kind of follow the same train of thought as well. So if we have a patient who maybe they were eating a hot dog, it's July 4th, they were eating a hot dog and they swallowed a part of the hot dog and went down the wrong pipe and it lodged in the right main stem bronchus. It's important to note how much air is getting into that lung at that point. Is it totally occluded, completely blocked, or is the patient getting air in the lung? So what we may do is an inspiration, expiration chest x-ray and see if that diaphragm moved at all. So that could be presence of foreign body showing diaphragm movement, but there are certain conditions that could cause the diaphragm not to move on its own, phrenic nerve issues. So when we make an x-ray, what we want to do is we want to have the patient hold their breath at the end of the second inhalation. So both textbooks are going to say, I think maybe all 3 textbooks are going to say on what we want to see are on either an AP or a PA chest x-ray are 10 posterior ribs. And you're going to have you might have a tough time identifying posterior from anterior ribs, but it's really not that complicated. So the ribs wrap around the backside of the patient and they actually touch the spine in 2 different places. So you've got connectivity between the rib and the spine. So if we just pick a rib, this is a 6 rib, and if we wrap around, you can see that the rib turns and it just kind of disappears right there. And the reason it disappears is because you don't have anterior ribs. You've got a small portion of anterior ribs, but most of your what we would refer to as anterior ribs are what we refer to as costal cartilage. So that's cartilage that attaches from the rib and it goes all the way to the sternum. So if it doesn't look like it's touching the spine, it's anterior rib. If it does, then it's posterior rib. So we want to be able to count 10, but the issue is that the first and second ribs are stacked on top of each other. So you've got 1, 2, 3 is kind of behind that clavicle, so it's kind of hard to see. 3, 4, 5, 6, 7, 8, 9, 10. Our evaluation criteria for a good chest x-ray is to see from the apex of the lungs to the costophrenic angles. That's awfully close right there, but probably not a reason to repeat. top of the lung to the base of the lung are the costophrenic angles, apex to the costophrenic angle. Both sides on there without rotation. And what we're going to look at for rotation are the clavicles and their proximity to the spine too. The clavicles are your collarbones, and they're here. Your spine is back here. The two don't touch, but on this two-dimensional representation of the patient's anatomy, they look like they do. So what we're going to look for is symmetry here to determine rotation. We're also going to look at top to bottom, left to right, and we're going to talk about some other things that we need to look at too that just are not reflected in Bontrager's or the Merrill's. So this just shows us what our respiratory excursion is and kind of describes what happens whenever the patient breathes. So when you breathe, you've got a lot of stuff going on. So the diaphragm drops and it creates a vacuum to draw air in. At the same time, your ribs lift and separate so that what we get is expansion of the lungs in 3 different dimensions. It's all about creating a vacuum to draw air in. So as we inhale, you can look down and you can see as you inhale, your chest goes in and out. So that's your AP diameter. But also your lungs will expand laterally or transversely as well, and then certainly vertically as the diaphragm drops. So how this applies is that you need to make sure that you've got enough image receptor on your PA or AP chest x-rays to compensate for that. And you need to understand body habitus and how body habitus is going to affect the position and the expansion of the lungs. So your hyposthenic patients are going to have broad, short lungs, so your collimated field should probably be more broad than what it is long. Your asthenic patients are going to be exactly the opposite. They're going to be very thin and longer. The patients you're going to struggle the most with are your asthenic patients, your patients with a runner's build. So their lungs expand in all dimensions. It seems like their lungs go from their eyebrows to their kneecaps. So in my experience, the hardest people to get on an image receptor, especially when we used a 14x17 image receptor, the hardest patients to get on were people with runner's build. Hyposthenic patients, they're athletic, but they have a runner or a swimmer's build. So atelectasis, again, is collapse of lung. This is just, again, showing why you might do inspiration and expiration chest x-rays. So atelectasis, foreign body, fixation of the diaphragm, which could be caused by foreign body, and small pneumothorax, which would be your atelectasis. So your landmarks for your PA chest x-ray are... the textbook positioning is going to be to put your central ray at T7. So you can't really see T7, so you have to estimate where T7 is, and we've got some telltale indications. So on the posterior side, what you've got is this big knot on the back of your neck, and you can feel the back of your neck, and you can feel that knot. And what that is the 7th cervical vertebra, the spinous process that comes off of that, and that's what we refer to as the vertebral prominence. And so in females, T7 is going to be about 7 inches below that, and males it's going to be a little bit lower at about 8 inches. But where that's going to correspond is going to be the inferior border of the scapula. So your central ray in the middle of your collimated field should be somewhere around the inferior border of the scapula. This thing is something I've never used in my entire career, probably because I did not learn out of Bontrager's. If this works for you, great. I've never used it in my entire career. So on your anterior to posterior views, or whenever you're doing AP projection, then what you might find helpful is the distance from the jugular notch to T7, and that's going to be 3 to 4 inches below the jugular notch. And the jugular notch is right here. It's that soft tissue indentation right above the top of your manubrium. So just more of the same, more of the same, more of the same. And then your collimation guidelines, make sure that you don't collimate in so closely that it is going to cause a problem that would cause you to repeat the exam. So this is good collimation. So what you want is kind of close collimation, but not close enough that the patient might breathe themselves off of the image receptor. The center of the chest and T7 should be pretty close to the middle of the collimated field, so your collimated field is similar on top and bottom. You want to make sure you don't have rotation. We'll take a look at that here in a minute. So apex to costophrenic angle, side to side without any kind of rotation. Other things that you might want to consider is the position of the patient's head. So the position of the patient's head could cast an artifact, the base of the skull, over the apex of the lungs. You don't want to extend the patient's chin back that far. One thing that you might find helpful on full-size adults, this is not going to be really helpful on pediatric patients, but on full-size adults, is to put the top of the image receptor 1.5 to 2 inches above the relaxed shoulders. I say relaxed shoulders because some of your patients are going to walk around with their shoulders drawn up. So what you're going to have to do is you're going to have to talk the patient into relaxing their shoulders, and then put the top of the image receptor about 1.5 inches above the outer portion of the top of the shoulders. That's very helpful on full-size patients, and that's generally what frankly what I do. If I have a pediatric patient, then there's going to be a little it's going to be different. So on a PA chest X-ray, patient faces vertical grid, so mid-sagittal plane should be centered to the image receptor, and it should be perpendicular to the image receptor. So perpendicularity means that we've got things at right angles. These are going to become my clavicles here in a bit, but perpendicularity means you've got right angles. One thing is vertical, one thing is horizontal, and you've got perpendicularity. That is right angles. That is perpendicularity. So other things are to have the patient equally distribute their weight on their feet. If you don't do that, then you may have a patient lean themselves off the image receptor, or it could cause rotational issues. You see the way the patient has the back of their hands on their hips, and they have their shoulders rotated forward. The purpose for that is to take those scapula and rotate them out of the lung field in as much as you can. So I'm going to come back up to this image here. This is a scapula. Scapula is shoulder blade. And you can see that it's way out here on the periphery. If you can see that line right there, you can't even see it in the lungs. But if you can see that line right there and that line right there, that is what we refer to as the vertebral border of the scapula, and it's completely out of the lung field. So they did a really good job on this X-ray of getting those out of the way. So, and that's what the purpose for this is. All right, so what we're going to talk about is mid-sagittal plane for just a second. The mid-sagittal plane is a plane that's an invisible, imaginary plane that divides the patient into equal left and right halves. It cuts you straight down the middle. A sagittal plane is any plane that parallels the mid-sagittal plane. All the way through the registry, what you want to hang on to is the difference between sagittal and mid-sagittal. In your test questions, I give these test questions all the time, and students fall for them all the way into the sophomore year sometimes, is that if I ask you a question on mid-sagittal plane, or if I ask you a question more specifically on a plane that divides the patient into equal left and right halves, then that's a mid-sagittal plane. If I give you a question that says that the patient is divided into left and right portions, now it doesn't say even or equal, then that's just any old sagittal plane. So you've got dozens of sagittal planes, but you only have one mid-sagittal plane, and it divides you into equal left and right portions. All right, so the central ray should enter the mid-sagittal plane at T7. level of the inferior border of scapula. You make your exposure at the end of the second deep inspiration. So you're positioning your patient. You want to make sure you shove your bucky in. The image receptor is still sticking out there. So image receptor all the way seated. Have your hand on the patient and tell them, I want you to take in a big deep breath. And the purpose for having your hand on the patient is to kind of subconsciously tell them, don't move as you breathe. So they take in a big deep breath and you tell them to blow it all the way out. Take your hand off of the patient, and while you're walking out of the room to go make your exposure, tell them, I want you to take in another big deep breath. Make sure your collimator light is still on. Take another big deep breath, watch them, and whenever they get it all the way in, you say, hold it, and at that point you make your exposure. And if everything else was right, you should not have to make a repeat. So your basic chest x-ray routine is PA and lateral. Next recording, I'm going to talk about some specialty views along with the lateral. I'm just focusing on PA and AP at this point. So PA sitting at the wall bucky is certainly an option if you can put them on a stool. I've done this exactly one time in my career, and that was only because I walked into the patient's room and the patient had just completed eating breakfast or lunch or whatever. They were still sitting on the side of the table, or I'm sorry, on the side of their bed. So I just moved their bedside table, gave them the image receptor and told them to hug that, and I shot the image from behind them as a PA seated chest x-ray portable. Only did that ever once in my career. So most of the time it's going to be AP if you're in the patient's room. Be concerned about where this patient's hands are in this image. If this patient has very long lungs at all, they may be in the way. A better placement for those hands would be on the hips to rotate the shoulders out of the way. So your AP, if the patient can't get up and you can't shoot PA, then you can shoot AP. You want to shoot PA because it puts the heart closer to the image receptor. But if the patient can't get up, you're going to have to shoot AP. Want to shoot PA, may have to shoot AP. So a few things about that is that this patient is semi-upright, and in being semi-upright, they refer to that as a semi-Fowler's position. So that's number one. Number two is that you want the patient to be seated upright as far as possible, but a lot of patients aren't flexible enough to do that. So what you want to resist is to raise the patient's bed up as far as the patient can raise up, and then expect that you would put the image receptor behind the patient without hurting the patient. So bring the patient up a little bit, go ahead and then pull them forward, put the image receptor behind them, and then bring the head of the table up a little bit further. I'm sorry for all the fidgeting. I'm kind of uncomfortable. I'm having some health issues. So bring the head of the table up a little bit, put the image receptor behind the patient, and then bring it up the rest of the way. Your central ray, though, on an AP should be perpendicular to the sternum. So regardless of what position the patient is in, my sternum is here, so the central ray should be about like that if I'm in this position. If I'm kyphotic and I'm leaning over, that just means we change the angulation of my central ray. If you have a patient, and that would be somebody who is probably an older patient who has multiple compression fractures in their spine, but if you have a patient who is hypersthenic and their hips push them further away from the image receptor, then you may have to angle CAUDAT. So in these images, what you're seeing is kind of a reflection of that. You want your central ray to be perpendicular to the sternum. Some of your textbooks say that you want the central ray to be perpendicular to the image receptor. I'm going to tell you you're going to have positioning errors with that. So perpendicular to the sternum regardless of what position the patient is in. All right, so just more of this. I do want to come back to this. Notice that this patient has their arms out and away from their body, and that's very important to make sure that you don't get skin folds over the lateral portion of the lung field. But also it looks a little bit like they've had the patient rotate their shoulders forward. And that is a positioning point, even on AP, that most people just ignore and don't perform. I would really recommend that if at all possible, you do that as well. It's really more of the same stuff. More of the same stuff. And what you should get, regardless of if it's AP or PAs, you should get 10 posterior ribs in an ideal situation. You're going to have situations where you're not going to get 10 ribs. If you have a hypersthenic patient, their lungs tend to be shorter, so you might not get 10 ribs. If you have a patient who just can't get a good inspiratory, they just can't give you a good inspiratory effort for whatever reason, you might not get 10 ribs. For example, if you have a patient who has a big distended abdomen, full gas or whatever, they may have a hard time taking in a big deep breath. If you have a patient who just had a heart surgery, they might have a hard time taking in a big deep breath. So our technical factors for our chest x-rays are going to be 110 to 125. Most of the hospitals I've been used 110. You would use a grid or a wall bucky with those kind of KVPs. If though you've got if you're doing a portable and you're not using 110 KVP and you're using maybe 85 KVP, you may be able to forego the grid. But you want to use a high MA and a short exposure time so that you don't have a motion artifact. If the patient can't hold their breath well, then you may introduce a motion artifact. Also, the heart's going to be beating throughout the exposure, which could introduce a motion artifact as well. So I don't know that these two are truly the same patient. The patient on the left here is quite sick and it almost looks like a trauma patient. Looks like we've got subcutaneous emphysema, which would just be free air in the tissue, which would indicate maybe multiple rib fractures, and with multiple rib fractures, we probably have a pneumothorax. Also with that pneumothorax, we may have a what you would refer to as a hemothorax. So blood inside of the pleural space, and that may be what they're trying to get at here. Is this was taken supine, and we can't see this lung because we've projected a lung straight down onto a massive amount of fluid. It almost looks like we've got a chest tube right here, and that would be another indication for a chest x-ray. If the patient has a hemothorax, a pneumothorax, or any other cause of atelectasis, then they might put a chest tube in the patient and hook that patient up to some sort of suction to try to get that stuff out of there and reinflate that lung. So we don't want to see rotation. We've got a slight amount of rotation. We're going to look at something a little bit more dramatic here, but again, our rotation, we're going to evaluate the ends of the clavicles and where they appear to be in relationship to the spine. So in this case here, what we've got is a situation where the patient's chin is tucked. It's very common on AP chest x-rays, especially if your patient's in a semi-forward position, you set the patient up part way and they have a tendency to tuck their chin a little bit. So be on guard for that, just watch for that, and make sure the chin's not tucked and it's not extended so far that the base of the skull might get over the top of the lungs as well. So this is ideal, this is not. Okay, so every textbook that you're going to run into says that if the patient has large pendulous breast, to ask the patient to move the breast out of the way for a chest x-ray. I'm not going to advise you to do that in this world where everybody's offended or weirded out by something that might get you a report. According to the textbooks, if the patient has very large breasts, these aren't exceptionally large, then you should get them out of the way so that they don't cast a shadow over the lower part of the lungs. So file that away. Large pendulous breasts need to be removed for a PA chest X-ray. Whether or not you ask a patient to move their breasts out of the way is entirely up to you. So this is just showing you that, like in this case, the center of the central ray may have been here, or the center of the lungs were here, and it should, center of the central ray was here. And what that gave us was a large area of exposed upper abdomen. So sometimes you're not going to know because you can't possibly know how sick the patient is. We've got some other positioning errors that we're going to talk about here in a minute. If you look at where the clavicles are, this is the aortic arch. That's where the aorta comes out of the top of the heart, and it makes a 180-degree turn, and it goes down and eventually becomes the abdominal aorta. So what you're looking at is as if you're, this is my microphone, if you're looking at the aorta comes up and it makes that turn and you're looking straight down onto it. So that's aortic arch. The clavicles should not look like they touch the aortic arch. And we'll talk about that here in a minute. So we've talked about this, top to bottom, left to right, aortic arch, no rotation. You should see the domes of the diaphragm, all the stuff. More of the same stuff. More of the same stuff. Your criteria, you should see the entire lungs without rotation, scapula removed because you rotated the patient's shoulders. Full inspiration gives you 10 posterior ribs. Remember, your posterior ribs go all the way to the spine. Equal collimation at the top and the bottom, no motion, and your exposure factors should be right. AP should really be the same as PA. I don't know why they selected this as their their ideal exam for AP chest X-ray. This is a really, really sick patient. Looks like if you look at the soft tissue and compare that to the bone, this patient's got what looks like advanced osteoporosis, maybe with a clavicle fracture. The shoulders are elevated, the clavicles are too low in the chest. It's just not a very good X-ray. PA chest X-ray and our AP chest X-ray should look the same. The only difference might be the magnification of the heart and the difference in the appearance of the marker. So just more of the same stuff. Okay. So this is where the Martinson book really sings. The Merrills and the Bontrager tell you what the X-ray should look like, but they don't go far enough to show you what something that's wrong should look like and how to fix it. So that's where the Martinson book comes in. If you teach in a program, I highly recommend the Martinson book. Try to plug it in where you can. If you're in a 4-year program, certainly you can find a place for it. If you're in a 2-year program, you got to get kind of creative. It can be kind of tedious reading through all the stuff, but, you know, face it, Merrills and Bontrager are too. It is worth teaching out of. It's worth it for the students to develop their personal skills or professional skills. So what we have here is rotation. This is AP chest X-ray. We have rotation. So if you look at the spine is right here, and you look at the clavicles, this is one end of the right clavicle. This is the medial end of the right clavicle. Medial end of the left clavicle is kind of buried inside of the thoracic cavity, and it's behind the spine. We have rotation. Okay, so this is where my wooden spoons come in. So this is an AP projection, right? So it's an AP projection. These are my clavicles. That's my spine, okay? So where the clavicles should look like they are is in contact with the spine, but they're not. So in this particular case, what we've got is the right posterior side is up against the image receptor, and the left and left side is elevated. Okay, so it's portable chest X-ray on a really sick patient. So what we've got is this. So you see, this is my right hand, right? So this is my right clavicle, and I've got an increase in distance between my clavicle and my spine, right? And that's exactly what you're seeing right here. So this patient is in a RAO position. That's if the patient's AP. And so if the patient was in a it's an RPO position. RPO position. AP projection, RPO position. So if the patient was in an LPO position, we would see separation between this clavicle and the spine. So that's AP. This is going to be a little bit more difficult for PA. I don't have a mirror in front of me. This software doesn't show me a image of myself, so I'm working off of a stripe at the top of my computer that's about that wide where I can see my reflection. So if then we were to be shooting PA instead of AP, everything would reverse. All right, so this is my spine. Now, the spine is processed, taken out that way. This is my spine, and these are my clavicles. I am in a PA projection. So in a PA projection, if I were to be in now this would be my right side. If I would be in a RAO position, I would have separation. Okay. That would be an LAO position. Doing this backwards is not as easy as you might think. So everything's going to be backwards. So if I'm in an LAO position, I have an increase on my right-hand side, an increase in distance between my clavicle and my spine. Okay, so that's what's going to indicate rotation, is where your spine and your clavicle appear to be. We also have another issue with this this image. The positioning of this image, and that is, this is a first rib, this is second rib, this is third rib, fourth rib, all the way down to the fifth rib. We see the fifth rib, it looks like it's going directly into our aortic arch. And what that means is that we've got a misangulation or a mispositioning in my mid-coronal plane as well. So mid-sagittal plane rotation gives us our true rotation, but mid-coronal plane tilt gives us something different. All right, so if we've got our clavicles again here, and let's say the patient is kyphotic, what that's going to do is it's going to push the clavicles deeper into the chest X-ray. So this patient was not only rotated, but they were also kyphotic, or at least the central ray was not perpendicular to the sternum. It was angled deep into the sternum. So it was angled too much towards the feet. Now, is all this worth repeating? Well, you got a lot of stuff going on here. The center of your central ray is not centered up with the patient in the middle of the image receptor. You've got a little bit of rotation. You've got a little bit of a caudal angulation on your central ray. But take a look at what's going on with this patient. If this was a difficult position to get the patient into because they're very uncomfortable, they just had open heart surgery. So that's what all these wires are. They just had open heart surgery. There's still on telemetry. They may be miserable. This might have been hard for them to get into position. So if the doctor is there waiting for the image, before I went back in and repeated this image, I would probably approach the doc and say, can you see what you need to see? Or do you want me to repeat this image? If the doctor's not there, then the prudent thing to do would to be repeat the image. But anytime you are going to repeat an image, change something. If you go back in and you do the exact same thing that you did before, you're going to get the exact same result. So a lot of different things that we could be identifying on this image. Any one of these positioning areas might or might not be a reason for repeat, depending on what the doctor is looking for. So this is the same thing. We've got a central ray 2 caudad. We've got first, second, third, fourth. At least the fourth possibly the fifth. It looks like 1, 2, 3, 4. Yeah, at least the fourth. Maybe a little bit further. Our relation is too caudal on that one. So this one is exactly the opposite. So if our central ray angulation is too cephalic, then what's going to happen is the clavicles are going to come up, right? So the clavicles should be around T3 or the third rib. And these are completely covering the apex of the lungs. Now, there are times that we want the clavicles to be projected up, preferably above the apex of the lungs. And that's what we'll call a lordotic chest x-ray. That's not what we've got going on here. We've taken a look at the entire lung and about half of the abdomen. But again, we've got a patient who's had open heart surgery. They've got a central line. What is it we're looking for specifically in this image? Are we looking for the central line placement and whether or not it's in a good spot? If the answer is yes, then this is probably a pretty good image. If the answer is no, or the doctor's not around, most of your techs would be hard pressed to repeat this image, but what you as a professional need to see is you need to recognize this and not make the same mistake on the next one. So this is the last thing that we're going to talk about, and this is not a conclusive list of pathologies, but the pathologies that we might see on a chest x-ray. We've got foreign bodies, aspiration, leading to things like what we talked about before, issues with the diaphragm, not moving properly. Consolidation is just I won't say it's a catch-all, but it kind of is. If the patient has increased density, increased markings in their lungs for reasons that they don't know exactly why, maybe the patient was in a car wreck and had a pulmonary contusion, basically a bruising of the chest and some infiltration of blood into the lung tissue, then they may call that consolidation. If we've got localized areas or smaller areas in the lung that they think the patient has a pneumonia, then they may call that localized consolidation. Pulmonary edema, for whatever reason, they may call all that consolidation. Atelectasis, we talked about. Atelectasis is collapse of the lung. What's causing the collapse of the lung? Is it a pneumothorax? Is it a pleural effusion? Probably two of the more common pathologies that we see in the lungs. Cancer, pretty common, a lot of times secondary. And what cancer looks like in early stages of cancer before it really becomes dense is that if you were to take an x-ray image and you were to take a cotton ball and dip it in milk and then put that on your screen at any part in the lung, that would kind of look like a cancer. So what a cancer looks like is it's subtle and it's an area of decreased radiographic density, so slightly lighter, indicating an increase in patient density. So that's something that's going to confuse you, not cancer, but the density thing is going to confuse you quite a bit over the next couple of semesters. Next semester. So COPD, chronic obstructive pulmonary disease, maybe bronchitis, maybe emphysema. Bronchitis, to me, is a little bit harder to see. Emphysema it has a specific presentation. So you got a patient and they're on oxygen and they're wheezing, and you take an x-ray of them and their lungs are very dark and they're exceptionally long and the domes of the diaphragm are kind of flat. Those are all telltale indications the patient has emphysema. So emphysema is loss of elasticity of your alveolar sacs. And what happens is that the alveolar sacs inflate, but they can't really deflate very well. So you have a tendency to look at a patient who has emphysema and they're wheezing, and you think, well, the patient's having a hard time breathing in. But it's really not the case. They're having a hard time breathing out. They're alveolar sacs are inflated, and they're, I won't say frozen inflated, but if you take it, just try this little exercise. You're taking a big deep breath, and then you relax, and your alveolar sacs collapse, and they cause the breath to exit your lungs. With emphysema, it doesn't happen that way. The patient takes in a big deep breath, and then they have to work to get the air out. So what you're actually hearing when they wheeze is their attempt to exhale, as opposed to asthma, maybe inhalation and exhalation. Cardiomegaly, we're going to see, again, not really a catch-all, but you may have some things like heart valve issues that cause one portion of the heart to increase in size, cor pulmonale, or you may have congestive heart failure where you've got the pericardial sac full of fluid, and it's causing the heart to have to work harder to pump. So all of those are pathologies that we might look for on chest x-ray. It's not a comprehensive list, but those are some of the things that just came to mind when I was putting this together. So we're going to pull up there. The next recording, I'm going to talk about lateral chest x-rays. I'm going to talk about two specific specialty views, that being apical lordotic and also the decubitus chest x-rays. The analysis on both the decubitus chest x-ray and the apical lordotic are going to be very similar to AP and PA, so it should be a shorter video. I thought this was going to be a shorter video. It didn't turn out that way. So I thank you very much for your time. I thank you for watching. I would really appreciate if you got anything out of this, if it was helpful for you to study or learn material or review for your reaccreditation or your initial accreditation, please give it a thumbs up. It just helps to bump the channel up and get more exposure to more people. We're a small community, so the more that you can do to help it to reach other people, the more it will reach other people, and the more I'd appreciate it. Thank you very much.